no meat and no dairy, follow a vegan diet, no cooked foods, no sugar, no gluten. There are a lot of no's here. So what should people with stomach cancer eat? I've been a registered dietitian for 19 years. I could never come up with an edible meal plan that is keto, vegan, all raw foods, gluten-free. So instead, in addition, I want to acknowledge the fact that for people with a diagnosis of stomach cancer, it's often hard to eat in general. It can be hard to digest comfortably, hard to absorb specific micronutrients, and hard to maintain weight. So putting those variables together, it can be harder, if not impossible, to find anything to eat. After a partial or a total gastrectomy, it's even harder to eat, harder to digest comfortably, harder to absorb specific micronutrients, and harder to maintain weight. So we're going to start today by redefining healthy eating. Instead of listing all of the foods not to eat, let's instead ask what a healthy diet should be doing for our bodies. A healthy diet provides foods that make you feel energized. They allow you to maintain a healthy weight, allow you to maintain your lean body mass, meaning your muscle mass, your bone density, and provide the right amount of nutrients for your body, not just calories and protein, but vitamins and minerals as well. A healthy diet or healthy eating also supports your recovery after treatment or surgery, prevents unhealthy weight loss, and is tailored to your nutrition needs. Because nutrition is not one size fits all. Nutrition needs differ from person to person, and nutrition needs change based on your age, your lifestyle, and certainly after a diagnosis such as gastric cancer. Therefore, the definition of healthy eating needs to be individualized based on treatment course, weight trends, activity level, GI symptoms, among other variables. Furthermore, nutrition is not just about food, it's about eating, and eating is complicated. We eat for reasons other than hunger, and the foods that we eat aren't usually prescribed for us. We choose food based on cultural norms and family traditions. We use food as part of celebrations. The foods we eat on a day-to-day schedule differ based on our work schedules or our school schedules or the kids we're taking care of or the parents we're taking care of. So we need to consider all of these variables when designing a meal plan and eating plan at different stages of treatment and after gastrectomy. I want to again highlight Dr. Rhodes' presentation this afternoon because she's going to talk about some of these variables, specifically in helping people navigate incorporating these norms into their new normal after a gastrectomy. So in our time together today, and I think we have an hour and a half, so we will have plenty of time and plenty of time for questions at the end. I'm going to discuss the nutrition goals during cancer treatment and review broad general tips pretty quickly about to make eating easier during cancer treatment, meaning chemotherapy or radiation. We're going to spend most of our time talking about eating and nutrition after gastrectomy, which I refer to as the post-gastrectomy diet and lifestyle. We're going to discuss long-term nutrition concerns after gastrectomy. Dr. Davis started talking about a few of those, but we'll go into some more detail. And then I'm going to provide my top 5 recommendations for people who are preparing for or who have already had a gastrectomy. Evidence-based diet and nutrition information, including some new online resources that our team at NIH has collaborated with No Stomach for Cancer to put out. And then we'll have plenty of time at the end for questions. So starting with nutrition goals during and after treatment. So during cancer treatment, a primary nutrition goal is to minimize symptoms that make it harder to eat, which can include poor appetite, feeling full quickly, nausea, changes in bowel patterns, and changes in taste and smell. A second goal is to prevent unintentional weight loss. That's a big variable that we need to address because the goal is to maintain lean body mass. When somebody's losing weight because they're having trouble eating or trouble absorbing, they're not just losing fat tissue, they're losing a disproportionate amount of their muscle mass. It's also important that people are able to maintain enough weight to maintain their strength for treatment and good quality of life, because losing too much weight can actually lead to treatment delays. And we also want to minimize the health consequences of poor nutrition or malnutrition. We also need to prevent or treat micronutrient deficiencies. So then again, big overview of healthy eating. When we look at the nutrition guidelines to meet nutrition goals during cancer treatment and after gastrectomy, the diet looks very different than the general nutrition recommendations. For the general population, the goal is to avoid excess nutrition. Because when it's easy to eat, it's easy to overeat. So we need to make sure to balance high-calorie foods with many lower-calorie foods to achieve a healthy weight. That means eating a large variety of fruit and vegetables and whole grains, and eating only when hungry to avoid overeating. But because of the reasons we discussed already, the goals are different and the focus is different after a diagnosis of stomach cancer when it's hard to eat. And the goal is to avoid undernutrition. This could be a hard mental shift for many people, especially people who have struggled or changed their diet in their previous years to try to avoid gaining weight, and now we have to do a complete 180 and focus on high-calorie, high-protein foods, especially when appetite is low, because the goal is to keep weight up instead of to lose weight. It's important to choose foods that are well tolerated, which many times are not a large variety of raw fruit and vegetables, especially during clot or other chemotherapy and right after a gastrectomy. Avoiding too much fiber, especially in the setting of poor appetite, early satiety, because fiber is very filling and then it's hard to get enough calories, and in the setting of diarrhea. And eating on a schedule, regardless of hunger cues. And this is really hard for a lot of people to unlearn what they've been told their whole life, which is to eat when you're hungry and stop when you're full, and they have to make themselves eat even when they don't feel hungry. In both cases, though, the recommendation is not to use supplements to prevent or to treat cancer. So a quick note on supplements, and we will come back to vitamins, but a quick note here. As recommended by the American Institute for Cancer Research, American Cancer Society, and the NIH Office of Dietary Supplements, supplements should not be used to prevent or to treat cancer. And they shouldn't be used in place of a healthy diet. Supplements need to be used with caution because they're not regulated like medications are. They can interfere with prescription medications, they can interfere with chemo, and they can cause other complications. So it's important to discuss all supplements with your physician, your oncologist, your dietitian, and whoever else is helping with your care. When supplements are needed, choose those that are third-party tested and follow good manufacturing processes. That gives you assurance that what's listed on the label is actually what's in the bottle. Ooh. However, supplements are needed in some situations, such as to treat a deficiency. Vitamin D deficiency is common among all adults, regardless of diagnosis. To prevent deficiencies for specific diagnoses, and to prevent deficiencies after gastrectomy, which we'll talk about in a few slides. But first, let's talk about some tips to make eating easier during chemotherapy. So poor appetite or feeling full quickly is very common with the diagnosis of gastric cancer, and especially during treatment. To manage these symptoms, general tips include eating small meals often, getting away from the 3 meals a day pattern and grazing all day, every 1 to 2 hours. Choosing high calorie, high protein foods and drinks. Drinking your calories. When you don't feel hungry, when you don't want to eat, the actual act of chewing food can actually make that symptom worse and may even trigger nausea. So using protein shakes or smoothies is a good way to get nutrition. Sipping on fluids between your meals instead of with your meals to prevent you from feeling full too quickly. Avoiding the sight or smell of food between meals. This one is less obvious for many people, but being surrounded by food a lot of the time when your brain is not telling you to eat can actually make it harder to eat when it comes time. Distracting yourself while eating, instead of just staring at the plate and saying, I have to eat this, I need to get through this, trying to distract yourself, watching your favorite show, talking with friends, playing a game on your phone. Opposite of what you would expect a dietitian to tell you to do, but distract yourself while eating so you can get the food in. Create a pleasant eating environment, avoiding stressful conversations around meals, especially conversations about how much did you eat enough, did you drink enough. And accepting help from others for everything from cooking to grocery shopping, meal prep, to try to avoid being around food, especially if it's unappealing. Another common side effect during systemic treatment of chemo is nausea. And many of the management strategies are the same: eating small meals often, choosing bland foods, and foods don't have a strong smell because the smell from food can trigger nausea for many people. So that often means choosing cold or room temperature foods that don't have the vapor that's going to trigger that reaction. Choosing lower fat foods can also help with nausea because they clear the stomach more quickly, so avoiding greasy or fried foods. Sipping on fluids between meals instead of with your meals, again, to prevent feeling too full. Avoiding the sight and smell of food between meals, and asking for help with food prep. Nausea meds, antiemetics, are also very useful and often necessary, so making sure to time the nausea meds around meals to get the maximum effect. Another common side effect are changes in bowel movements, both constipation and diarrhea. To manage constipation, the first recommendation is to increase fluid intake. Most people are trained to think fiber, but the recommendations for fiber are actually a ratio of grams of fiber to calories. And a number that many people have in their heads, because they see in terms of general nutrition, is we should be eating 25 to 35 grams of fiber a day. But that's for someone who's eating 2,000 calories. So when it's hard to eat, and you're eating far less than that, that's way too much fiber for that ratio. Being active when able, moving around helps the intestine move, and talking to your team about medication if needed. Diarrhea, the opposite problem. Management strategies for that include avoiding certain types of fiber called insoluble fiber, just like the peel of an apple, beans, nuts, seeds, the visible fiber in whole grain breads. That can make diarrhea worse. And instead choosing foods with soluble fiber like oatmeal and bananas, applesauce, peeled potatoes. Again, increasing fluid intake to replace what is lost. Eating small meals often, which is going to be the theme I keep saying. Resting after eating, and again, talking to your team about medicine if needed. So going back to how nutrition recommendations can change, a key point here is that a high fiber diet is not always healthy. It can make specific symptoms actually worse. And then changes to taste or smell, another common treatment side effect. To manage those, include marinating food to change the flavor, such as sweetening foods that taste salty or bitter or acidic. Using paper or plastic utensils if there's a metallic taste in the mouth to avoid that additional metal. And keeping your mouth clean. Brush and or use mouthwash between meals to help avoid those taste changes. For changes to smell, avoiding foods and drinks with strong smell, which again may mean cold or room temperature food so there isn't a vapor. Using cups with lids, and eating in well-ventilated areas. So having a poor appetite and all of these symptoms I already mentioned often lead to unintentional weight loss during treatment. So you want to use the previously mentioned tips and strategies to make it a little bit easier to eat. But as we discussed in the first slides, the goal is to minimize weight loss before and during treatment. So additional strategies, just to review one last time: eating small meals often, keeping favorite, well-tolerated foods on hand. This means it likely won't be a wide variety. So again, we're not looking at the 20 different fruits and vegetables in a day. We're looking at the foods that are best tolerated to make sure that you're getting the calories and protein that you need. Choosing high calorie, high protein foods and fluids, and avoiding unnecessary diet restrictions. As we talked about in the first few slides, those extra diet restrictions make it even harder to get the nutrition you need. If the weight loss is because of a gastrectomy, there are additional diet modifications and lifestyle modifications that we'll talk about next. So moving into nutrition after gastrectomy. Before I go into this topic, I got to meet a few new faces today and was told things that I've heard many times when seeing patients at my age. For people who've had their surgery elsewhere and they were discharged from the hospital after gastrectomy and told just eat what you can. And that's a recommendation I strongly disagree with, and I'll go over why. As kind of a method to my madness of why I recommend certain advances of diet slowly and progressively. But before I get into those details, I think it's helpful to first review the roles of the stomach to put the pieces together as to the why we recommend certain modifications after gastrectomy. So to review, the role of the stomach contributes to hunger signals, physiological processes that send signals to the brain that tell you to eat. The stomach can also hold a large quantity of food. It can expand to hold more than a liter of food and fluid at a time. The stomach prepares food for absorption. The intestine is where the majority of nutrients are absorbed, which is why you can live without a stomach and still eat by mouth to get your nutrition. But the stomach prepares food mechanically by grinding food into a puree so that it can be absorbed into the intestine, and chemically by mixing food with digestive enzymes and stomach acid. The stomach also controls how quickly food moves into the intestine, which is what we need, because even though the small intestine is very long, 25 plus feet long, the small intestine needs time to absorb food, so we don't want it to move through too quickly. So after gastrectomy, especially after a total gastrectomy, there's the loss of the normal hunger cues. I say normal, and I use that word kind of broadly, because what's normal when you don't have a stomach? But the loss of normal hunger cues mean the stomach growling that sends that signal to the brain to tell you to eat, which can cause a complete absence of hunger for at least 6 to 12 months after gastrectomy. For some people that I've worked with who are years and years and years out, they still say they don't feel any hunger signal. They just eat because they know they need to eat. And for other people, the signal comes back in a different way, like they describe feeling empty or feeling light and knowing they need to eat. And then there are a few people on the complete opposite end that say they feel hungry just like they did before. So the body does adapt, but there is at least a period of time when eating means eating on a schedule, not because you feel hungry. Without the stomach to hold a large quantity of food, that means needing to eat small meals frequently and needing to change what and how you eat to prevent something called dumping syndrome, which we'll go over in a few slides. Without the stomach to break down food for absorption, food must be chewed very thoroughly before swallowing. Many times people come to me very frustrated that they can tolerate a food one day and they can't tolerate it the next day. And we go through the details of what were you doing when you ate it yesterday and it went well. And they were sitting at their table, eating slowly, they weren't rushing out of the house, but the next day their toddler was screaming for something and their second grader was late for school and they were eating really quickly and they didn't chew it thoroughly, and looking back they realized that was the situation. So chewing very thoroughly is important every time. Without the stomach acid, an intrinsic factor to prepare certain nutrients for absorption, specific vitamins are needed. That's my soapbox, and we'll get to that in a few slides. And without the stomach to control how quickly food moves into the small intestine, again, there needs to be some diet modifications, changes in what you eat, how you eat, when you eat to prevent dumping syndrome. So because of all these changes and the loss or reduction of stomach functions, if it's a partial gastrectomy, post-gastrectomy symptoms include feeling full very quickly, the loss of appetite or hunger, nausea, which can happen for many reasons, one being trying to eat too quickly, too much, constipation, which is often due to not getting enough fluids, early dumping syndrome, late dumping syndrome, bile reflux, food aversions, and the fear of eating, which often results from the above symptoms, and dysmotility. So some of these symptoms get better with time from surgery, but many of the symptoms can actually get worse, including these last 4 in red. Dysmotility.
Thank you. I was gonna say that.
Dysmotility means when the, if it's a total gastrectomy, when the esophagus is not moving like we expected to, changes in how the GI tract is moving.
Like when your food gets stuck?
When your food gets stuck. Yes.
I have these all the time.
It's horrible.
Any other questions before?
Sorry.
Does that just happen in the esophagus or anywhere within the digestive tract?
That's a good question. So we see it often in the esophagus. If food is getting stuck, a workup usually includes evaluation for a stricture. I'm not going to talk about Dr. Davis's rates, but I know offhand we have very few strictures, I believe 2. And it's usually dysmotility when things are not moving normally because the esophagus is not moving as we expect it to.
But it usually occurs there.
Yes. Yep. So if the small intestine is not moving normally, the colon is not normal, that's a different situation than when food isn't going down smoothly, which is separate from having trouble swallowing water. Having trouble swallowing plain water, as many people here probably know, is very common after a gastrectomy and very frustrating. We don't lump that into dysmotility. So because of all these symptoms, unintentional weight loss is basically expected after a gastrectomy. From the literature, the rates are reported of 10 to 40% of pre-op weight. I'll share our exact numbers from NIH a little bit later, but we've seen less than that, we've seen more than that. A total gastrectomy results in more weight loss and more permanent weight loss than a partial gastrectomy. And people who are heavier before surgery lose a greater percentage of weight loss than people who are lighter. But the goal, or my goal, is that the diet and lifestyle changes help manage and ideally prevent, as best we can, these post-gastrectomy symptoms to slow down the rate of unintentional weight loss and ultimately maintain a healthy weight long term. So let's break this down into the details of the post-gastrectomy diet. I'm looking around and see many faces in the audience who could give these next several slides without me. So bear with me because there are faces in the audience I don't know. But I'll go, if I'm going too fast, raise your hand, but I'll go through these pretty quickly. So as we discussed, chewing food thoroughly is needed because the intestine can't absorb food if it's not broken down. Eating on schedule, not waiting for hunger cues, especially after a total gastrectomy when there's only so much food that's going to fit. If you miss one of the small meals or skip a meal, you can't double up the portion next time and get the calories. Those are just calories that don't get in that day. Again, eating small but frequent meals, because an appropriate portion size right after a total gastrectomy is 1 to 2 ounces of food total for what I'll call that meal. So more like a newborn baby portion size. That means eating at least every 2 hours during the waking hours. And with time from surgery, portion sizes do increase, but that takes time. The adaptation after the surgery for the intestine to be able to tolerate bigger portions is usually about a year. So this next slide shows an example. Yes?
I don't think my family actually chews food. I think we just bolt it. Like, when you say chew thoroughly, does that mean like chew a bite 20 times? If somebody's gonna learn how to do that for the first time in their lives, you need to
Yes,
roll
chew until it's pureed.
Okay,
Shouldn't be chunks or pieces.
okay. Thank
Right
you.
after the surgery, again, eating too fast or not chewing thoroughly enough, body will give immediate feedback like, oh, that didn't go well. The cramping, the pain, the bloating, which then you don't want to eat again, but you need to eat again.
Is there, I think part of it too is eating too fast still.
Mhm.
Are there like concrete tips you give people around, I mean, not to be just, it's just really hard to slow down when you
Yeah.
eat fast your whole life, like.
Yeah.
Yeah, but once you're there, it's, you don't have a choice. You know, and it's like,
Yeah, your body.
It'll
that's
tell
well
you.
said. Your body will
It'll
stop
tell
you.
you.
Okay.
Yes.
You spoke a little bit ago about grazing and eating and not to skip meals. My son says Alexa reminds me that I have to eat, and it's like, I feel it's before I have to eat.
Yes.
And it's like, I don't even sometimes get the 3 meals in, and then I have to eat more. It's like, oh, just the thoughts of food is like,
Yeah.
so how do you?
Yeah. So I count a meal as anything with protein. So it doesn't have to be.
Cashew is a meal.
You can take a few bites. You say, our deal is, we're gonna take 2 bites. If I can do more, I do more. If I can't, I'm done. But anything with protein counts. So stomach or no stomach, most people eat more than 3 times a day, meaning they put something in their mouth more than 3 times a day, but whether they call it a meal, it's kind of semantics.
Candy.
Candy's not a meal. That's how my daughter's. Peanuts.
It's got protein.
If it has 1 gram of protein, so we'll say, I'll qualify that. Thank you for helping me clarify. If there's more protein in it than carbs, we'll call it a meal, even if it's just a few bites. But it is unrealistic to make a meal and sit down and eat every 2 hours. That's not going to happen for anybody. So that grazing where it's just kind of a few sips, a few bites, while you're doing the rest of the things that you're doing in your life. But yes, for the person who asked about chewing thoroughly, that's a body feedback signal that your body will slow you down. That's not dietitian led. I don't have to keep pounding that because your body will stop you if you're going too fast. So this sample meal plan, this is meant for like the first few weeks after surgery. This is not forever. But you'll see that most of the foods and fluids, we need to kind of bulk them up to get as much bang for the buck as possible. So you see a lot of protein powders, protein drinks, because when the portion sizes are so small, for an adult to get enough calories and protein to meet their nutrition needs, we really have to go for density. And you also see that solid foods are separated from fluids. There's a few reasons for this. One is that fluids mixed with solids is much more filling. So if you drink and eat at the same time, you're going to eat less. That's actually a weight loss strategy. That if I were a weight loss dietitian, which is not what I am, but if I were and I was counseling people on drink a glass of water before you eat your meal, then you're going to eat less. But the fluids also move things through the intestine more quickly. And as we mentioned a few slides ago, we don't want things moving through the intestine too quickly. Because without a stomach and without the pylorus, I use my hands a lot when I'm counseling, but without the pylorus to hold things in, and now it's more, the plumbing, as Dr. Davis would say, is more like a tube, things will go through more quickly. And fluid makes the intestines contract. Because there isn't a control here to hold them in. So separating fluids from solids helps your intestine absorb more to prevent dumping syndrome. This is something that usually improves with time from gastrectomy, but for some people, they cannot drink more than a few sips when eating, even long term. Yes?
What's an example of protein
There are actual products that are just protein enhanced waters. There's a whey protein added to them. Example brands are like Protein 2O and Ready Water. They're not, sometimes they're flavored, sometimes they're not, but they're not, for the ones that I recommend, are not sugar sweetened. They're similar in the surface tension and in the ability to drink them as some of the clear protein drinks, which I know some people like, some people don't like, but there are clear liquid protein drinks such as Premier Protein Clear that we use right after the surgery to start getting protein in when we're limited to clear liquids. Okay. So dumping syndrome. I know many people here are familiar with this, so I'm going to go through it quickly again. Throw a hand in the air if I'm going too fast, because I don't want to bore anybody. There are two forms of dumping. Most people, when they say dumping, are referring to early dumping syndrome. And that's caused by the rapid release of highly concentrated food or fluid into the small intestine. It happens soon after a meal, within the hour. And symptoms, the hallmark symptom for many people is they need to rush to the bathroom. Episodes of diarrhea, nausea, cramping, flushing, palpitations, or low blood pressure. And it contributes to food aversions. So many of the recommendations and the guidelines that we give to people right after surgery to prevent early dumping syndrome is not just to prevent dumping itself, but to really avoid food aversions. Because once your brain is telling you not to eat and not to try a food, that's a lot harder to overcome than me physically telling you, these are foods to try or these are foods to avoid, because the brain is smarter than we want it to be. Dumping syndrome also contributes to malabsorption and weight loss. So to prevent early dumping, small frequent meals, chewing very well, separating solids from fluids, eating protein with every meal, and avoiding added sugars, which are ingredients that are added to the food to sweeten it. Late dumping syndrome is sneakier, and it's harder for many people to identify because it's not a GI reaction, it's a blood sugar reaction. It's caused by a rapid rise in blood sugar, which causes your pancreas, which still thinks you have a stomach, to dump out a lot of insulin and results in a low blood sugar. So symptoms of late dumping syndrome are symptoms of hypoglycemia or low blood sugar. And it can include any of these: double vision, lightheadedness, sudden confusion, trouble with word finding is a very subtle symptom that many people describe. Fainting is a more severe one. We have had people fall and break a bone from late dumping. Hot flash, cold sweats, becoming very irritable, that hangry sensation. And this happens anywhere from 1 to 3 hours after eating. So again, it's harder unless you're aware of it and looking for it to realize, like, oh, I thought I tolerated that candy because I didn't have diarrhea, but 3 hours later, I couldn't see anything and I couldn't remember my dog's name. That's late dumping. So prevention, same strategies, with the addition of not correcting low blood sugar with added sugar. So this is different than someone who has low blood sugar because they're diabetic. For someone who's diabetic but has a stomach, whatever they eat and drink to get their blood sugar up is still going to stay in the stomach and have that slow release into the intestine. Whereas after gastrectomy, what you eat and drink goes through much more quickly. So we don't want juice, candy, sugar, because that's going to cause the same response with another episode of late dumping. So instead, using a carbohydrate with protein to get the blood sugar up. So examples are peanut butter, like the unsweetened peanut butter. I have a packet in my bag if anyone needs one. Unsweetened applesauce with a protein like a yogurt or a peanut butter, but something that has some carb but some protein to get the blood sugar up without that reaction of then having a low blood sugar. Any questions about late dumping? So I feel like that's a sneaky one that there isn't as much information out. Okay. Added sugars. So most people are able to identify the predictable sources, the candies, the syrups, the sodas. But there's a lot of hidden sources of added sugar too to be aware of. Things from yogurts, ketchups, sauces and marinades, salad dressings, granola bars, traditional protein drinks like Ensure and Boost, many restaurant meals. So I have a nutrition facts label here. This is a yogurt, which many people don't consider a dessert or a sweet food, but this yogurt has 10 grams of added sugar. So this would not be a good option for someone who had a gastrectomy. Instead, finding a yogurt that has 0 or maybe 1-2 grams of added sugar, but will have the same protein and calories. Yes?
Okay, forgive me because I'm squeaky.
That's fine.
When I was diagnosed 13 years ago and had my gastrectomy, the only thing the dietitian told me at that point was to eat Greek yogurt. And that's been my go-to. Even now, 13 years later, instead of the regular yogurt,
Yeah.
the Greek yogurt is the best. But don't choose a yogurt, go with Greek yogurt.
Yeah. Protein
Protein.
and unsweetened. And luckily now, there are so many products that don't have as much added sugar because of the public health awareness that added sugar is not good for any population. Kids have too much sugar, adults have too much sugar, people in the United States have too much sugar, so there's many more options. Yes.
How careful do people need to be about sugar substitutes in foods? Because sometimes can't those like ferment or cause other problems? Or is it
So-
okay to have anything that just has that instead?
Sure. So sugar alcohols cause a big problem for many people, stomach or not. They are known to have a laxative effect. So things like sorbitol, resveratrol, anything with an OL on the end, there's usually a warning label on those products may have a laxative effect.
Oh, okay.
Sugar substitutes won't cause dumping per se, but there are some people, regardless of the gastrectomy, who don't tolerate certain sugar substitutes. So that's pretty individualized.
Great.
Yes.
Maybe a lot of spouses, sweet spouses, is sort of at least, I don't want to eat and to go and drink at least an Ensure. I just don't want to eat. So I don't drink the Ensure anymore.
So the Ensure Max or the Ensure?
Max,
The Max. No, that's fine.
I think that's what she wanted you to say. Or there's
Sorry,
other
gotta
ones.
take the husky side on this one. If you can't eat,
I can't hear, sorry.
if you can't eat, I don't want you getting weak and not being able to do the things you want to do.
Should I say that to Alexa?
So if it's not the Ensure Max, that Max means it doesn't have sugar, added sugar, but it has the extra protein. It can be a Greek yogurt. It can be something else. It doesn't have to be the Ensure Max, but eating something rather than nothing. Yes.
I'm 3 years post-gastrectomy, and when I was going through my chemo, I really just couldn't eat anything. And so they were telling me just eat anything you possibly can get in your stomach, or not stomach at that point, in your body, to maintain. So sugars were easier for me to break down. So I would like go with dark chocolate or something like that. Now I feel like I'm addicted to sugar. Is it more of a problem because it absorbs quicker?
Yeah, and it can, so a few things there. And I pause because I always have like 10 follow-up questions to answer a question like that, which is why it's hard to give specific nutrition recommendations in a setting like this because it's so individualized. Because if somebody's coming to me and their vitamin and mineral levels are in the tank and they're telling me they're taking their vitamins, then I'm looking for why are they not absorbing. And then it may be that they're dumping more than they're aware, they're not absorbing it as much. Or people come in and they tell me they're tolerating sugar. You know, just this morning at the hotel, these people travel to NIH and they stay overnight at a hotel and they come in. The breakfast buffet, I had pancakes with syrup and a banana. And I was like, well, we did your blood work and your blood sugar is 40. So you're dumping, but they don't feel it. And that's concerning and consistent with what I see in that the later from surgery, the symptoms of low blood sugar, it takes a much lower low blood sugar for a person to feel symptomatic, which is not what we want, right? That is not helpful because I don't want your blood sugar to be 20 when it should be 100, because then it's way too late, then it's an emergency. So sugar long-term is a concern. And something I would say to work on. It's not to say that you can't have any added sugar after a gastrectomy. People that are years out will argue that point left and right, and I agree with them. But it's that it has to be a more strategic approach to eating sugar, not just like not having eaten for several hours and grabbing a bag of Skittles. That's not going to go well. Instead, okay, I had my meal, I had good protein in it, and I'm going to have a few bites of my partner's dessert, and then I'm going to have protein again before I go to bed, because otherwise your blood sugar is going to drop overnight. And we've had people who have had very scary circumstances where they woke up overnight and their spouse thought they were drunk because their blood sugar was so low. So sugar is always something to be aware of, because your symptoms of low blood sugar may not arise until your blood sugar is super low. Yes?
So is stevia okay?
So stevia shouldn't cause dumping, and as long as you tolerate it, it should be okay to use. Yes?
So, I mean, I know obviously you want to avoid added sugars, but how cautious should someone be about like the adding of the raw sugars? Like someone whose diet is really high in fruits.
As long as the fruit is eaten with protein, it's fine. So fruit won't cause that early dumping, but meals or snacks, and again, meal, I say basically anytime you're eating, because it can be a small portion. If it's just fruit, not followed by some protein later, your blood sugar will rise, your pancreas will release insulin, and your blood sugar drops. So I've had people who have had late dumping from eating watermelon. Yes? Yes?
I'm squeaking again.
Okay.
When I was diagnosed eons ago, my oncologist recommended, and I want to hear your opinion on this because I tell people to do this. If I'm wrong, I want to know. Ensure and Boost went right through me.
Yes, right.
He told me low sugar carnation instant breakfast and to make a smoothie out of it with protein or Greek yogurt, whatever. He said that if you looked on the side of the carnation instant breakfast, it has a lot of vitamins and nutrients. So I'm telling people that, so tell me if I shouldn't be telling people that.
So,
Because I still use it.
okay.
If I'm losing weight and I've got
Yeah.
bed, that's my go-to.
Yes. So a few points there. One, 14 years ago, that was one of the
Probably
only
only
products on the market.
Right.
So there's many more low sugar, no sugar protein drinks available. So there's nothing magical about Carnation Instant Breakfast Light Essentials, which is the low sugar one now. It's an option. It's not my favorite in terms of the nutrient profile, but it's an option, and I like that you said that you add protein to it, because by itself, it's still higher on the added sugar side.
Right.
So as long as you're balancing that out and adding protein, that's fine, but knowing that there are many more options out there too is good. How about, we'll do 2 more questions and then we'll keep going, because I might answer some of these questions in my other slides. Go ahead.
So I wear a CGM because I had such crazy blood sugars after I ate so many shots that were so rapid.
Yeah.
But even if I eat carbs, I still will jump to 300, even brutal as this.
Mhm.
And then I'll come crashing down and I'm catching about 50 with the CGM. If I just eat like vegetables and meat, I won't go up as much or won't, but I can't gain weight on
Yeah.
that. So I'm still really low weight.
Yeah.
Suggestions, because I just do this all day long.
So, yes, and I've worked with people who have been in your situation, and what that took was, they kept a very detailed food log for me, what they ate, when they ate, and I marked it all up. And this has been for people who have had their gastrectomy, not at NIH. And the last I heard was that at least 3 people were able to come off their monitors with diet modifications, but it would be very specific to what ratio of carb and protein you need. Because the leaner you are, the more sensitive you are to insulin. So when you lose so much weight after a gastrectomy, it's kind of a double whammy because your pancreas is still acting like your stomach is there, but you're so lean. That's why one of the recommendations on the flip side of nutrition, when we're talking about diabetics and you want to avoid having to give them insulin, the first intervention is to have them lose weight because then their cells are more sensitive to their own insulin. Now, on this end of the spectrum, when you're very lean, you respond to insulin very well. Your pancreas is doing what it's supposed to do, but it's too much. So I would say working with a dietitian in addition to your team at home, and we'll talk about the team component in a few slides, to really get into those details, because that's a very specific question. I want to be able to say, just do this. Okay. So why don't we go through the next few slides, because I think I'll cover some of these questions hopefully, and then we'll go back to more. So we've talked a lot about the post-gastrectomy diet and lifestyle. I'm not going to read through all of these points because you all are proving to be experts in this. I do want to talk a little bit about bile reflux because that is an issue that comes up for many people. So the post-gastrectomy diet and lifestyle is not just how frequently you're eating and what you're eating and eating on the schedule and getting the protein and avoiding the added sugars, but it's also modifications about physical positioning both day and night to prevent bile reflux. So as many of you are familiar with, bile reflux is the burning sensation of bile coming back up into the esophagus, and it's often triggered by physical positioning. I have people who tell me they can't bend at the waist to tie their shoe, otherwise bile will come up. They have to squat down. So preventing, managing bile reflux, again, it's the same food strategies. Eating small meals often. Trying to eat too much can actually trigger bile. Remaining upright after meals and having good posture. What was interesting to me is at the start of COVID, when everybody went virtual, I had many people calling me and saying that all of a sudden their bile reflux was worse, it was so much worse. And I asked them what's changing, and we're getting to their schedule, it's they're hunched over, leaning over their computer all day instead of being up and about and walking. So that physical positioning can have a big difference. Sleeping with the head of the bed elevated at least 30 degrees, using wedge pillows. Some people buy adjustable beds, but there are many different pillow arrangements. Bending down at the knees instead of leaning forward at the waist, especially people who enjoy gardening or even just picking up after their kids at home or cleaning their house. The repeated bending at the waist often triggers bile for many people. And avoiding constipation. Constipation is a big trigger. It seems to be with the pressure below from constipation, bile can't come down, so it's more likely to come up. And then talking to your team about medications if bile reflux continues despite these modifications. And something to keep in mind is this is not reflux from stomach acid. So proton pump inhibitors and H2 blockers are not appropriate. I have met with several people who had their surgery outside of NIH, and they're coming to us saying they can't manage their bile reflux, and they're on something like Privosec. And in the absence of stomach acid, meaning after a total gastrectomy, that's not going to be helpful for bile reflux, at least in our experience. So, going through, oh, yes.
The only med who's ever been offered for bile reflux is Carafate. Is there anything else that you could take?
Yes. Cholestyramine is our next go-to after Carafate. Now, so Carafate kind of soothes the area, and cholestyramine binds the bile.
Well, most doctors tell him that's not what his problem is anyway, so they're like, don't even seem familiar with it.
Okay, and yeah. Now keep my mouth shut. Okay, so we talked about all of
Say that
this.
joke one more time.
We talked about the diet, we talked about the physical positioning, and then the final piece of this puzzle is the micronutrient supplements, the vitamins. So I am going to get a little bit sciencey on this and kind of give my justification for the vitamins to help explain the whys. So in looking for evidence-based recommendations for vitamins after a gastrectomy, clearly total gastrectomy is not that common of a surgery, but gastric bypass is. So a Roux-en-Y gastric bypass uses the Roux-en-Y reconstruction that is often used for partial gastrectomy and is used for total gastrectomy. So that's a very common weight loss surgery in the US. The most recent numbers I saw was like 40 to 50,000 per year. So it looks like this, where, again, I don't have a pointer, but you can see how it was similar to Dr. Davis's picture. This is for a gastric bypass. Now this surgery is designed and proven to induce weight loss by reducing oral intake, meaning the foods that you're able to eat, and by reducing absorption. So it's known to cause micronutrient and macronutrient deficiencies. And again, this is the reconstruction used for many partial gastrectomies and for total gastrectomies. So as a dietitian, this is one of my favorite pictures because it shows where everything is absorbed. So I want to point out a few things to explain why vitamins are so important after this surgery. So first, you see here that intrinsic factors needed to absorb B12. And B12 is actually absorbed, though, at the very end of the small intestine, the terminal ileum, but it's prepared for absorption in the stomach. Iron is reduced by stomach acid into a form that can be absorbed in the duodenum and proximal jejunum. And same for calcium, absorbed in the same location. Pancreatic enzymes are released into the duodenum for digestion of protein and fat. But the Roux-en-Y bypasses these areas, the duodenum and proximal jejunum, meaning food doesn't go past there anymore. So absorption of these micronutrients from food is definitely not 100%, and it's not enough from food alone. So after gastrectomy with the reduced stomach acid, we have decreased absorption of iron and calcium. With the reduction or absence of B12, absence meaning the total gastrectomy, decreased absorption of B12. We have impaired absorption of iron and calcium with that reconstruction, delayed mixing of food with bile and pancreatic juices, so that's decreased absorption of fat and fat-soluble vitamins. A faster transit time, which is decreased absorption in general, and decreased intake due to the post-gastrectomy symptoms, which results in decreased absorption of all nutrients. So in the literature after gastric bypass, the micronutrient deficiencies that are well documented include vitamin B12, which has many consequences, including anemia, peripheral neuropathy, which is the loss of sensation in like fingertips and toes, changes in how you're thinking, as severe as dementia, the prevalence in that population of up to 20%. For zinc deficiency, consequences include hair loss, taste changes, or loss of taste, diarrhea, infertility, and changes in immune function, and that prevalence has been estimated up to 40%. Thiamine deficiency, which can cause weight loss, anorexia, many mental changes, confusion, short-term memory loss, something as severe as encephalopathy. It can be life-threatening if not caught in time, and that prevalence is up to close to 50%. Iron deficiency, which is well known to cause anemia, but also causes fatigue, weakness, lightheadedness, changes to your nails, shortness of breath, reduced productivity, and decreased physical capacity. And that prevalence is up to over 55% in the gastric bypass population. And calcium and vitamin D, with consequences of rickets, which is softening of the bones, and osteopenia, osteoporosis, and bone fracture, with a prevalence of up to 100%. So the question is not if people develop deficiencies after gastrectomy, but which deficiencies and how do we treat them. So we can learn a lot from the gastric bypass population. The American Society for Metabolic and Bariatric Surgery has a wealth of data on deficiencies after Roux-en-Y and recommendations for specialized vitamins to lower the risk of deficiencies. Again, this is a different population, but appropriate to compare to this population for the analogous surgery because of the Roux-en-Y reconstruction. So these guidelines clearly state that after weight loss surgery, patients need to be on vitamin and mineral supplements for life, and that people who don't take the vitamins every day can suffer from severe and even life-threatening medical problems due to low vitamin and mineral levels. So again, this is why it's my soapbox. People will say, when they meet with me, several people in the room can probably vouch for me that I'm not the food police, but I am the vitamin police, because I want to prevent these problems. So here's a comparison of one specific bariatric multivitamin. It just happens to be the one we have on formulary at NIH. I have no ties to this company, but it's third-party tested and follows good manufacturing processes, ProCare Health. I have that in comparison to the guidelines after Roux-en-Y. And then in this final column, with many values in red, it's comparing to a Flintstone multivitamin with iron.
I was just gonna say, you please say no Flintstone vitamin.
Yes. You could say that louder for the people in the back. So you see here in red, all of the values that do not meet the guidelines after Roux-en-Y. I did pick this multivitamin specifically because when I do meet with people, and I think I've met with somewhere between 40 to 50 people who have come to NIH but have had their surgery elsewhere, if they're taking any vitamins, they're taking Flintstones. And it's not surprising then that they have multiple micronutrient deficiencies when they're relying on a standard multivitamin that's designed for a child with an intact GI tract, but they are an adult with a total gastrectomy. So these guidelines also recommend calcium supplementation with a dose of 1,200 to 1,500 milligrams per day for gastric bypass. I err on the side of 1,500 because this is a total gastrectomy. The recommended form is calcium citrate because that's the form that can be absorbed without stomach acid. And to enhance calcium absorption, calcium needs to be taken in divided doses and 2 hours apart from iron supplements because iron and calcium bind together and then they're not absorbed.
How far apart should we be taking our calcium?
About 2 hours.
Oh.
Yeah, so if you get on the every 2 hour schedule, that means a multivitamin, 3 calciums, so 2 hours apart. So sharing some of our results from NIH, where I have been working on the protocol at NIH that Dr. Davis introduced. So I've been working with patients since 2017 on this specific protocol. And the most common deficiencies we see after total gastrectomy for people, even when they're taking the appropriate and the recommended multivitamin, are these 4. Many people are surprised to see that B12 is not on this list. When B12 is taken orally in the appropriate amount every day, we don't see a B12 deficiency, but it has to be taken every day in the right amount. Iron deficiency is the most common deficiency we see, and it's consistent with how iron is absorbed, as we already discussed. So it's important to monitor iron panel trends and to intervene early when iron is starting to drop. A common question I get from other people or a response when people go to their primary care or their home team is that they were feeling tired, so the doctor checked their B12 and it was fine. In my experience, it's more often iron deficiency than a B12 deficiency when someone's taking the appropriate vitamins. Iron infusions can be used to treat deficiencies. We use them quite frequently. We also see zinc deficiency, and when that needs to be treated, it needs to be treated in the appropriate ratio of zinc to copper. So it's important not to just go out and get a high-dose zinc supplement because that can actually cause a copper deficiency. Vitamin D deficiency, yes. Yes. That's diagnostic of an iron deficiency. Yeah, yes.
If you have patients that live in Colorado, like areas with higher elevation, do you look at their iron deficiency a little bit different?
I look at trends. I don't just look at iron at one time because I look at iron, let's say, someone had their gastrectomy 6 months ago and they come in and I'm looking at their iron in clinic that day and their ferritin is 40. Okay, that's normal, but their ferritin was 140 6 months ago. That's a different story than if their ferritin was 40 6 months ago. So I'm always looking at the trend. Oh, yes.